Okay, good afternoon, everyone. I'm Dr. Rob Murphy, and I'm the Executive Director here at the Havey Institute for Global Health, and John Philip Fair, Professor of Infectious Diseases, Professor of Biomedical Engineering at Northwestern University's Feinberg School of Medicine. Thank you for taking the time to join us this afternoon for our latest installment in the Havey Institute for Global Health's first Friday seminar series. Global Health at the AAP, Applying Our Mission for Children Everywhere is the title. Please take a moment to follow us on Facebook and Twitter at #FSM Global Health. In addition, we welcome you to become an Institute member to receive access to special resources and services that support the research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Today, we're very thrilled to have Dr. Beena Kamath-Rayne join us. She's a neonatologist and Vice President of Global Newborn and Child Health at the American Academy of Pediatrics. She leads the AAP's Global Newborn Health Initiatives, plus the simulation and clinical skills training programs. She is a master trainer for the Helping Babies Survive programs, the Associate Editor for Helping Babies Breathe, second edition, and represented the AAP on the WHO Technical Working Group that revised the Essential Newborn Care Course, incorporating HBB's learning methodologies. Dr. Kamath-Rayne brings expertise in clinical research and quality improvement, which was resulted in grant funding in over 70 publications. There'll be time for questions following the presentation, in which we welcome you to submit your questions through the Q&A feature at the bottom right-hand corner of your screen, not to be confused with the chat function. So please put your questions in there, and I will be reading the questions directly to Dr. Kamath-Rayne. And now, Dr. Kamath-Rayne, I turn it over to you. Thank you very much for joining us today.
Thank you so much, Rob, for that kind introduction. It's really a pleasure to be here with you all today. I'm newer to the Chicago area, but have been thrilled to be able to continue doing some clinical work through Northwestern. And so it's nice to be exposed to other parts of that community and meet all of you. Well, I really appreciate the opportunity to talk to you a little bit today about our work at the AAP and what we're doing in global health. So I'm just going to jump right in. And so my hope is that at the end of this presentation, you will be able to demonstrate some knowledge of our mission at the Academy, discuss the activities that our Global Child Health and Life Support team do, and then awareness of how you may be able to get involved in some of that work. So I want to first start by telling you a story about my own personal journey in global health. So I am a neonatologist by training, as you heard Rob say, and in between my residency and fellowship, I took 2 years off and went and worked abroad. The first year I spent in a really small town in Ecuador called Guadalupe, and you can see me there with one of my former co-pediatric residents who came to visit me during my time in Guadalupe. I worked in this clinic where you can see people lining up. They came from miles away to purchase the ficha or the ticket to be seen by one of the physicians there. And I had an experience during that year which really changed the trajectory of my career. So I had been following this woman, Rosa, during her pregnancy, and at the latter stages of her pregnancy, I told her that when she was ready to give birth, she needed to go to the closest hospital, which was 90 minutes away in a town called Zamora by the bus. And what I didn't really understand at the time was that people had a very different perspective on the quality of care that they would get in the hospital. And so many of them actually preferred not to seek advanced care in the hospital. And so one night I got a knock on my door at about 10:30 p.m. and Rosa's friends had come to get me because she was ready to deliver her baby. And so the nurse from the clinic and I packed a bag of equipment and walked across that hanging bridge that you saw in the previous slides, crossed the river into the town and went to Rosa's house. And when I assessed her, she was having contractions every few minutes, and I recognized that it would be too unsafe to bring her back to the clinic for a more controlled delivery. And so it looked like we were going to have to deliver the baby in Rosa's house. And so there we were in this 1-bedroom house where Rosa was writhing on a plastic sheet in one bed, and her other 2 children were fast asleep in the other bed. And so I had her husband boil some water so we could sterilize some equipment, and prepared an area where we could receive the baby and do neonatal resuscitation if necessary. And then the nurse and I worked out a plan where once the baby was born, I would take the baby and assess the baby, and then she would continue to assess Rosa to make sure there wasn't excessive bleeding. And I have to say, this was one of the scariest moments in my career, thinking that even though almost half of the women worldwide deliver at home, if something had gone wrong in that moment, we were all that Rosa had in order to make sure that she and her baby had a good outcome. Well, I'm happy to report that there was a good outcome. After a few hours of labor, Rosa gave birth to what appeared to be a healthy baby girl. And I took that little girl over to the place where I'd set aside to do neonatal resuscitation and started to dry and stimulate her, and she cried, meaning that she was breathing okay. And Rosa herself did fine. There was no excessive bleeding. We got the baby cleaned up and gave the baby back to Rosa so that she could start breastfeeding. And then we continued to follow up with Rosa and her baby over the first month of life, several visits, in the first week, and then spacing them out as the month wore on, just to make sure that breastfeeding had been established and there were no other concerns. So this story has a happy ending. And I've been able to go back several times and visit Rosa and her baby. And in many places around the world, people don't name their babies in the first few months because many of them die. And when the baby was about 4 or 5 months old, I saw Rosa in my office, like writing things down, looking at my name tag, and she ended up naming the baby Beena. And so it's been a pleasure for me to go back and visit baby Beena and think about this experience that really changed the trajectory of my career, to understand that many women around the world and many babies around the world are born in these types of settings. So just to give you some background demographics, there are approximately 130 million babies that are born worldwide every year, and about 60 million of those occur as home births. And when I first started on this journey in the mid-2000 decade, our numbers had been 4 million babies die in the first 4 weeks of life. But we have actually made significant progress, and we're down to 2.4 million babies that die in the first 4 weeks of life. But that still accounts for about 6,700 newborn deaths per day. So there's more that we can do to improve these statistics. And if we look at the global causes of neonatal death, we often talk about the big 3, and those are infection, intrapartum related events, or you may also have heard the word birth asphyxia, or complications from prematurity. And so those make up the top 3 reasons why newborns die in the first month of life, which is the definition of neonatal mortality. Now, if you compare that to why newborns die in a setting like the United States, it's actually prematurity and congenital anomalies that are the top reasons why babies die. So there's a whole different epidemiology about neonatal mortality around the world. If we look at the timing of newborn death, knowing that neonatal mortality is death within the first month of life, actually babies and their mothers have the highest risk of mortality in the first 24 hours around birth. And then it spaces out across the remainder of the month. But the first 24 hours is really the highest risk for both the mother and the baby for dying. And so many of you have probably heard of the Millennium Development Goals. I'm not going to belabor this too much, but MDG 4 basically held the international community to the goal of reducing childhood mortality from the baseline by 2/3 by the goal year of 2015. And we have made significant strides in reducing childhood mortality due to things like vaccinations, treatments for diarrhea, pneumonia, et cetera. And so you can see in the blue line, the under 5 mortality rate has really declined significantly over the last several decades. If you look at neonatal mortality, however, which is in green, you can see that the decline is much less steep. And now that overall childhood mortality has declined, neonatal mortality actually makes up about a 50% proportion of overall under 5 child mortality. And so if we really want to make inroads in under 5 child mortality, we really have to spend some time thinking about the role of the newborn and how we improve neonatal mortality. And so the Sustainable Development Goals hold us to that overall goal, and specifically goal 3.2, which is by 2030, we want to end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce neonatal mortality to at least as low as 12 per 1,000 live births, and less than 5-year-old mortality to at least as low as 25 per 1,000 live births. Now, since the SDGs were put out, there's been another more focused Every Newborn Action Plan, which was put out in the year 2017, which really commits governments and their ministries of health to come forward with an actual national newborn plan, whereby each country around the world should have a national newborn mortality rate of 10 or less by the year 2035. And what that would mean is that it would result in a global average of 7 per 1,000 live births in the year 2035. So just to give you an example, the US usually has a neonatal mortality rate of about 4 to 5 per 1,000 live births. So this is a high ask for countries around the world where, when I first started this in the mid 2000s, we were talking about, some countries in sub-Saharan Africa with rates of, upwards of 40 per 1,000 live births. Now, one of the big challenges in doing work in neonatal mortality around the world is that 99% of those deaths occur in low and middle income countries, but most of our epidemiological research focuses on the 1% of deaths that occur in high income countries. And there's also huge disparities in the level of neonatal mortality that persist across regions and countries. So you can see in this sort of heat map, if you will, that in this data from 2020, we're still in areas of Africa dealing with neonatal mortality rates of upwards of 35 per 1,000 live births, and then some areas around Southeast Asia, and those are hot spots for where we need to do further work. However, as we continue to delve deeper in country-specific neonatal mortality, disparities also exist if we look, for example, between the poorest and richest wealth groups. So if we compare the poorest 20% and the richest 20% within countries, and I'm sure we could also put the US on this list, we can see disparities in neonatal mortality. And before I came to the AAP, I spent the last 10 years at Cincinnati Children's, and this was a community impact collective called Cradle Cincinnati that actually looked at our very high infant mortality rate in Cincinnati and mapped it out by zip code, and were able to see some signals of differences by zip code. So even though we may know a national neonatal mortality rate, it's also important to delve deeper where we may see other disparities that give important information about how we can better understand neonatal mortality and get at the root causes of what those are and make improvement. Now, add on all of that, we've recently been dealing with a pandemic. And COVID has really reversed decades of improvements on a variety of fronts. I'm sure you know that many newborns and children did not receive vaccination. So we're dealing with a gap in vaccination. And also, particular to newborn care, there's been disruptions in mothers seeking out facility-based services for delivery and then newborn care assessment after delivery. And so we're just now beginning to understand how this has impacted all of the improvements that we've made over the past decades. Now, I want to turn our attention and talk a little bit about the Academy, its mission, and the work that we do to try to improve this global landscape of neonatal health. So our mission at the AAP is to attain the optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. And we do this through our 3 pillars, which are policy, advocacy, and education. Now, on our team, which is the Global Child Health and Life Support Team, we are dedicated to fulfilling the mission of the Academy to attain the optimal physical, mental, and social health and well-being for infants, children, adolescents, and young adults. But we really want to emphasize the all. It doesn't matter where you're born or where you live in the world, but we want to apply our mission to children everywhere. And we pride ourselves on the clinical skills training programs, the peer-to-peer mentoring that we do, the technical support and systems-based implementation in which we collaborate with our global partners around the world to accomplish that mission. So this is our strategic plan here at Global Child Health and Life Support, and I don't expect that you're able to read the fine print, and I will take you through a little bit more of our goals, but our core values are about achieving excellence, creating innovation, and partnership. And our priorities are driven by the epidemiology of global child morbidity and mortality. And so our key goals are to develop, implement, and research curricula and interventions that are designed to improve the quality of care for newborns, children, and adolescents. And we do this through supporting our sister pediatric societies to achieve sustainable independence. We also want to provide our members with the skills and opportunities they need to improve the health of children around the world. And then we want to offer clinical skills training programs that are state-of-the-art in science, learning methodology, and technology. And so you're going to hear me talk about some of the programs which hopefully hit these goals. So this map highlights countries in blue where we currently are overseeing a public health program in collaboration with other partners or other sister pediatric societies. And so you can see that we have a footprint in quite a number of areas around the world. And it's important to understand that we could never do this work in isolation. We have partners from the work that we do on immunizations, integrated child health, newborn care, early child development, and non-communicable diseases. And it is with those partners that we're able to move the work forward and really improve the outcomes for children everywhere. It's also, I think, interesting to people to know that the AAP also applies for grants and does programmatic work. And so you can see a snapshot here of some of the work and topic areas that we cover. In blue are the topics that are covered by our global child and adolescent team. They have specific interest areas in mental health, immunizations and vaccine hesitancy, tobacco control, and early child development. And then in red, you can see some of the grants from my team where we're doing things looking at neonatal resuscitation, specifically via our Helping Babies Breathe program, which I'll talk to you a little bit further about. We also are starting to work in small and sick newborn care. We have a grant in Ghana. We are also looking at kangaroo mother care. And then I'll talk a little bit about some ECHO projects that we have as well. So under my area, which is global newborn and child health, there are 3 big buckets of work. There's first of all, the clinical skills training programs, simulation, and then our neonatal global work. And I want to make it clear because a lot of people are like, well, why did you come to the Academy? It seems like you're doing 2 very disparate things, but it's actually all very much related. And I'm going to explain how it all works. So some of you may be familiar with this formula for survival. And this formula was put out to discuss how someone may survive a cardiac arrest. And this can also be applied to a newborn who is born not breathing anywhere in the world. And so their survival depends on the best medical science coupled with educational efficiency. So knowing that the person that's going to provide the care to that baby has been trained in the most up-to-date science and knows those skills in the moment in the delivery room where that baby is not breathing and needs some sort of intervention. And then local implementation. So that person may know what to do, start bag mask ventilation, but if they don't have a clean bag and mask device at every delivery, that survival is not is not going to come to fruition. So the AAP has taken a role in all three of those things. So under clinical skills, our clinical skills training team, we oversee the neonatal resuscitation program and partner with the American Heart Association on pediatric advanced life support and guideline writings in the pediatric realm for both pediatric advanced, pediatric basic, and then neonatal resuscitation guidelines. And so you can see here the 5-year process by which there's evidence evaluation through ILCOR, the International Liaison Committee on Resuscitation, which results in consensus on science and treatment recommendations. And then the AAP and AHA write guidelines specific for neonatal and pediatric resuscitation specific to North America. And those guidelines then result in our educational curricula. And at the Academy, we have this vision where we're not only contributing towards evidence evaluation and guideline writing, but also research. So we actually have this delivery room intervention and evaluation network currently that's based in the US and consists of 6 sites that cover about 50,000 births per year, where we'll be doing delivery room resuscitation research. And we're hoping eventually this will also expand to include some international sites. We also have clinical skills training programs geared towards first responders. So the pediatric education for pre-hospital professionals, which is actually edited by Dr. Susan Fuchs, who's a pediatric emergency physician at Lurie. We also have a virtual reality program, which allows for those first responders to immediately assess and diagnose children who are ill, because the pediatric calls that they get are some of the scariest, but also less frequent calls. And so this allows them to do that low dose, high frequency practice to be able to better assess children during emergency situations. And then we have our clinical simulation program. So Michelle Olick-Smith is our director of simulation clinical skills training programs. And we have a simulation lab at the AAP. You can see we have 2 clinical workspaces. We have an RQI for NRP or RQI cart, which also has the NRP component with the neonatal mannequin. And we recently had several open houses where people were able to come in. And one of the things that we're really excited about in our simulation lab is that we have something called Sim Capture, where anything that we do in our lab can be broadcast anywhere in the world. And so we're really excited that we have the opportunity to potentially incorporate simulation into a more global facing educational opportunities for the future. Well, why am I talking to you about these clinical skills programs that seem to be based in the US? Well, neonatal resuscitation program, or NRP, was actually one of the first ways that the Academy got engaged in global health work. So NRP was transferred to over 124 countries and translated into 25 languages. But what some of the experts in NRP noticed was that in many places around the world, they didn't necessarily have the resources to take care of a baby once bag mask ventilation was started and a baby potentially needed chest compressions or medications like epinephrine. There really weren't the resources to do that. I mean, in some places around the world, particularly if babies are born at home, there isn't even oxygen. So what do you do in that situation? Well, if you look at the science of resuscitation, of the 130 million babies that are born around the world every year, all of them need immediate assessment at birth and simple newborn care. And that may be as simple as drying, warming, and stimulating the baby, things that you heard that I did for baby Beena in Ecuador. And about 5 to 10% of babies will require a little bit more stimulation, and then about 5% of babies will require bag mask ventilation. So if we think about it, over 95% of babies will come to or start breathing if we can get everyone to do these initial essential steps of resuscitation and then bag mask ventilation if needed. And what we're hoping to avoid are the over 800,000 neonatal deaths or birth asphyxia related deaths that are due to those interpartum related events. So babies that are, improperly resuscitated at birth. And in the background, there's also the 1 million stillbirths that occur around the world each year, and then the 350,000 maternal deaths. You heard me talk about the link between mothers and babies being at the highest risk of mortality in the 24 hours around birth. And what we're really trying to avoid are those babies that survive after improperly performed neonatal resuscitation, but have ongoing neonatal encephalopathy and then potentially become children or adults with long-term impairments potentially related to things like cerebral palsy. And so from all of this knowledge, the program called Helping Babies Breathe, no pun intended, was born in the year 2010. And this basically was a neonatal resuscitation curriculum, which is based on the same science and guidelines that we use for the NRP program. And so you can see these linkages now about why am I in this position? Well, both NRP and Helping Babies Breathe are reliant on the same evidence of neonatal resuscitation. But you can see that the algorithm for HBB is much simplified, it's pictorial, it's geared towards birth attendants that are around the world that may not have the same level of education as a pediatrician in the US. And you can also see that it's color coded. And so a baby that once you dry them is crying goes to the green zone and can receive essential newborn care with its mother. And a baby that's not crying then needs to be assessed, dried and stimulated more, and then potentially receive bag mask ventilation. And we aim to provide or help the baby to breathe either spontaneously on their own or with bag mask ventilation within the golden minute, so that we can avoid the long-term consequences of birth asphyxia, such as cerebral palsy. And HBB is over 10 years old now, and it's been implemented in over 80 countries around the world. It's been translated in 27 different languages. And originally there was a global development alliance with the partners that you see there, USAID, NICHD, Save the Children, and Laerdal Global Health, that worked to disseminate the educational program and work on implementation. And so the Academy was very proud to be part of this partnership and to be a part of actually that initial evidence evaluation around HBB. And so for the 10-year anniversary of HBB, which was in 2020, and actually corresponded to the 90th anniversary of the Academy, we did a lot of activities where we took a look back. There's actually a supplement to the journal Pediatrics, specifically just on HBB, covering things from the educational methodology, quality improvement, the impact of HBB on nursing and midwives, technology, that HBB has created innovation around. And so if you are interested, I can send the links for that supplement for anyone that wants further information. More recently, we've been very excited that the World Health Organization has taken note of the success of HBB. So if you look at the literature around HBB, HBB has actually been shown to reduce early neonatal mortality before discharge. So it's really difficult to get a measure around neonatal mortality because a lot of babies in global settings will go home from the hospital after birth, and then you may not know what happens to them afterwards. So the early neonatal mortality before discharge. But interestingly, HBB also improved stillbirth rates. And part of the reason for that is that likely babies were born still, but they actually had a heart rate. And HBB encourages people to assess those babies and try to dry and stimulate them. And so a lot of babies that previously had been called stillbirths were actually probably live born babies that had a heart rate, but were still. And through learning HBB, those babies were resuscitated. So based on that evidence, the WHO took interest. And so in 2022, earlier this year, the WHO released their second edition of the WHO Essential Newborn Care course. And so you can see that the action plan for the ENC course looks very similar to HBB. And in fact, the editors of HBB and members of the Academy were involved in the technical working group to make this transition towards the WHO ENC program. So ENC 1 covers that immediate care that would be incorporated into helping babies breathe through about the first 90 minutes of life. And then ENC 2 covers beyond the first 90 minutes of life until the baby is discharged home. So HBB was our, trademark initial program, which was followed by essential care for every baby, which continued to follow the baby through discharge. So basically what you're looking at here are the new and updated, now WHO endorsed HBB and ECEB plans that are now updated with the logo of the World Health Organization. And part of the reason for the shift to go to the World Health Organization is that many ministries of health around the world don't endorse a program unless it is put forth by the WHO. And so this is just another testament of the success of HBB, which is that we want to get it out even further, more broadly than what has previously done, because we know it's something that works. And what has been more recently a challenge is that HBB has typically been done face-to-face with one facilitator per 6 learners with this neonatally mannequin. And it's a low-tech, low-fidelity mannequin, which actually you can bag the mannequin and see her chest rise. You can actually simulate an umbilical pulse. There's a little red bulb that you can see. And when the facilitator presses that bulb, you can feel an umbilical pulse. But with COVID, we recognized that it was really difficult to take people away from clinical work and to gather in large groups to do training. And there were also travel restrictions. So how do you deal with that? So the AAP worked with Laerdal Global Health to develop something called Essential Newborn Care Now, or ENC Now, where we took the WHO Essential Newborn Care course and put it on a digital platform to do virtual training. And Laerdal developed this neonatally mannequin called Neonatally Live that connects to a Bluetooth to a tablet. And basically your learners can practice their skills of bag mask ventilation, and you can actually see a dashboard of how often your learners are practicing, what feedback they're getting about what they're not doing well, like they're bagging too fast, they need to position the head differently. And so you can actually run trainings in a virtual way and still have connection with your learners and be able to mentor them from far away. So the website where we've put this program is called hmbs.org. It's helpingmothersandbabiessurvive.org. And the goal is that the Helping Mothers Survive programs, which are the use the same adult learning methodology and that were overseen by JPIGO, are also on this website, so that anyone who's taking care of mothers and babies can use this website as a resource and find all of the educational curricula that would be needed to care for mothers and babies around that critical 24 hours after birth. So here you can see me using the digital flip chart, and you can see me demonstrating to my learners in Zimbabwe how to do bag mask ventilation. And so you have to get a little bit used to training virtually, in that you have to know how to position your camera so that the learners can see the movement of the chest as you're bagging the baby. And the picture there is another training that we did in Nepal with Dr. Sarah Berkelhammer and Dr. Michael Weisick, who are both on our Helping Babies Survive planning group through the Academy. Now, you saw me show the formula for survival, and that we want to rely on the most up-to-date medical science. We want people to practice their skills so that in the moment they can do it, they're able to perform that skill, so the educational efficiency. But now we really need to work on local implementation. So one of the really important lessons of HBB is that training in and of itself isn't enough. So you can do a one-day HBB workshop, and yeah, people will be able to perform the skills a little bit better after that training is over. But unless they continue to practice those skills and then work on behavior change and also systems-based improvements to really support what they learned in that course, a lot of what they learned won't be sustained over time. And so what we're starting to do now is develop more programs for what we can do to support ongoing mentorship and implementation after an initial ENC training. And so we've developed the customized mentorship and implementation support package, or CRISP. And what we're doing is developing these modules related to things like practice, like creating a system of ongoing practice, quality improvement, monitoring and evaluation, advocacy, how to develop good facilitators. And basically individuals that are interested in CRISP get a customized ENC Now training, and then mentorship over 4 to 6 sessions, which may be around 6 months, over the course of 6 months to a year, where their global mentor can assess what are the gaps in what they need to know about implementation, and then pick from this menu of modules and customize a curriculum for them to improve their ability to implement after that ENC training. And so this slide just shows some of the module names and components that I mentioned on the last slide, things like the data collection, quality improvement, program implementation, etc. So during the pandemic, we also had the opportunity to think about how to continue to innovate and deliver education. And so we at the Academy are a super hub for Project Echo. And for those of you unfamiliar with Project Echo, it's basically like a telementoring system, but it's an all teach, all learn model. And so we've been able to work with different pediatric societies and actually train them to be Echo hubs. And so we have a number of Echoes going on in global settings. For example, we were able to partner with the Midwives Association of Zambia and do a follow-on Echo to HPV training. So the Midwives Association of Zambia was trained to become an Echo hub, used that Echo infrastructure to do strengthening and implementation activities after HPV training. But interestingly, when COVID hit, they then also used that infrastructure to quickly disseminate information about COVID to a bunch of their learners. And so it's been really great to see how those partners have utilized some of those skills and technologies which we collaborated on with them, and continue to use those in innovative ways. So right now we have an Echo program that we're getting ready to start with Rwanda, looking at congenital anomalies. We also are getting ready to start another Echo in Tanzania, looking at ENC Now and then implementation support after that training. I now want to turn my attention to talk about global health education, which falls under my umbrella at the Academy. And interestingly, in a survey that was done of our members, about 1/3 of the respondents expressed an interest in global health, but 50% of those who responded to the survey didn't feel like they were well prepared to do global health. And so this really piqued our interest, because it seemed like there was a great deal of interest in doing global health, and pediatricians at all stages of their career were interested in seeking opportunities, but they didn't know how to get started. And so last year in 2021, we had our first global health education course, and our second annual course is coming up Saturday, September 17th. It is still going to be virtual. And we're hoping that maybe in 2023, we could do an in-person course. But what we're hoping to accomplish is, for those that are, as people are starting to register, there are online discussion boards where they can meet the faculty and have discussions about, why they're interested in global health, think through some difficult questions about, global health practice. They'll come together on September 17th and hear from the expert faculty on a variety of topics like the landscape in global health. There's a neonatal hot topics, pediatric hot topics. There's neglected tropical diseases. So a number of topics important to global health practitioners. We're also going to do a short introduction for a new course called GHERD, which is Global Health Education for Equity, Anti-Racism, and Decolonization. And those of you that know Dr. Elizabeth Gruthouse from Lurie, she was one of the physicians on the technical working group for GHERD. And GHERD contains 6 modules. You can see them listed here. There's probably about 30 hours of content, and it's not required to do all 30 hours. A facilitator may look and pick and choose what is most appropriate for their learners. But GHERD is basically meant to encourage people to understand some of the systematic imbalances in power that have traditionally been a part of global health practice, and understanding their own reasons for wanting to do global health, their own implicit biases that they may bring into the field with them, and how we can best mitigate those. One of the modules in particular, Taking GHERD Home, the history of the US region and anti-racism, is very popular with pediatric residency programs, which, whether global health residents or not, have chosen to use that module as a way to investigate systemic racism within their own communities and ways in which that may impact their pediatric patients. Well, how can you get involved? Whether you're a student, a trainee, whether you're a faculty member, there's opportunity at the Academy to get involved. You know, as you heard me say, we do a lot of advocacy. We have an annual advocacy conference where people go to Capitol Hill and advocate with their congresspeople on a variety of issues with kids. We do a lot of career development. There's a lot of opportunities to network, particularly at our annual meeting every year. This year, it is going to be in person for the first time in 2 years in Anaheim, California, October, I want to say 7th through 11th. And then there's also opportunities to join one of our committees, councils, or sections. So particularly under my area, we oversee 3 sections. One is the section on global health, the section on international medical graduates, and the section on simulation and innovative learning methods. Now, some of the sections do have an additional fee to join. I know that SOCILM, the section on simulation and innovative learning methods, is free. For those people that are students who may be interested in pediatrics, there's a much reduced rate to join the Academy, and then you automatically join the section on pediatric trainees. So if there's interest in joining, that information is easily available on our website. The other thing that we've been trying to do in our area is put out opportunities for volunteering on our various programs. So a big way in which we work on our programmatic work is we have technical advisors, some of whom are our members and some of whom are not. And so if we know of a new global health, for example, the GHEC course, the global health education course, we wanted to have a planning committee around that course. And so we put something out on the volunteer network. And we do usually include a trainee on all of our committees because we want to raise the leaders of tomorrow. And so we got, I think, 78 applications, and people that we didn't know were out there that had all this amazing experience in global health. And so the volunteer network has been a wonderful way to reach out and find other people in our membership, our 67,000 members, of what is going on, what are they working on, and also hear of their interest to participate in our work. So that was all that I had. If you're interested in any of the programs that I discussed, you can look for more information on aap.org. You can also write to us at aapglobal@aap.org. You can follow the AAP Global Health Twitter feed, or you can also follow me on Twitter. I do tweet about Academy things and also other things related to neonatology and resuscitation. And I will stop there, and I'm happy to take any questions.
Great. Thank you so much. Really appreciated the presentation. So we have time for some questions. You can put in the Q&A, or you can raise your hand and we can call on you. Any questions out there? I have a question. 2 participants raised their hand. Let's see, who is this? I can't see the person. But anyway, we're involved in the NEST study. Have you heard of that?
Nest 360.
Yeah, Nest 360 with
Yep.
rice. And I was
Yep.
just wondering, just kind of what's your take on that program?
So Nest 360 is basically a collaboration of a number of engineers that are looking at how do you make things higher tech by actually making them lower tech. So they're doing a survey of equipment used in NICUs and how those may be applied in NICUs around the world. So this partnership of Nest 360 has actually come to bear for the work that we're starting to do with small and sick newborn. So I mentioned a project which we're collaborating on with an NGO called Kabeli in Ghana. And what we're doing in Ghana is health system strengthening, whereby we're improving the referral pathways to the central Greater Accra Regional Hospital in the capital city of Accra. And the AAP was brought on board specifically to focus on the NICU component of this project. And so we've done some work with PATH, Cabela, who is the grant recipient, partnered with PATH and with Nest 360 to best understand what is the equipment that's most useful to invest our funds in. Because what often happens is that if the equipment breaks down in Ghana or another low resource setting, how do you maintain that equipment? How do you get replacement parts? How do you fix it? And so Nest 360 is doing great work related to the technology that we're going to need to battle one of those big three causes of neonatal mortality, which is prematurity.
Yeah, no, great, thank you. We have a question from Lisa Hirschhorn. How is AAP involved in the Alive and Thrive follow-up for premature infants who survive but need ongoing rehab, etc.? What are the research opportunities?
So Alive and Thrive, I'm not familiar that we are involved in an initiative around that. We do have a lot of work in early child development, and that work is being done on my colleague Terrell Carter's team for child and adolescent. And so we are part of a number of collaboratives basically around early child development that she is working on. We do have a study on my side of the team looking at longer term outcomes after HBV training. So we want to know whether there may be a trade-off in decreased neonatal mortality, but are we increasing babies that survive but with longer term adverse outcomes like cerebral palsy? So that study is going on in Zimbabwe, and we have engaged a developmental pediatrician who's also a member of the Academy named Suzanne Martin-Hertz. She's based out of UCSF, and she's our developmental pediatrician. And so we're doing follow-up from those babies that were resuscitated with HBV out through at least 6 months of age, and we're hoping to get further funding to do out even further through 2 years to look at those outcomes.
Great, thank you. Any other question? Oh, here's another one. Gerald Gunderson, I am involved with the clinic in Zambia and would like any information you have on your work in Zambia.
So that may be better to do offline if you want to send me an email. I'm happy to point out the work that we've mostly done has been around our collaboration with the Midwives Association of Zambia, which is run by a phenomenal and dynamic woman named Sarah Ngoma. And she has been a leader for the midwives during COVID and before that through our collaboration. And part of the way that we work is really try to build infrastructure through collaborating with our sister, either pediatric or other societies, and really give them the skills and tools that they need to continue the work on their own. And it's been amazing to see how they've used the echo technology to continue to disseminate information, as I mentioned, during COVID.
Great. All right, any other questions from anybody? You can put it in the chat, please, or excuse me, in the Q&A. That's better than the chat. I'll look in the chat too. No, they end up in sometimes both places. Well, if there's no other questions, let me just thank you again, Beena, for this great presentation and update on what's going on. Incredible work you're doing. I want to really thank you for all your insight and expertise today. And I also want to thank the audience for joining us and for submitting your questions. And we invite you to join us for the next installment of the Institute Seminar Series, which will be on Friday, October 7th, and feature Dr. Gene Kwan. He's a cardiologist, assistant professor of medicine at Boston University. And again, thank you very much for joining us today. Beena, thanks again. And for those who have registered, a recording of this webinar will be shared via email. And that concludes today's session. Thank you again. Thank all of you.
Thank you so much for having me.
We're